series. Our webinar today will discuss immunotherapy for brain tumors. My name is Jill Ann Demas. I'm the Senior Program Manager here at the American Brain Tumor Association, and I am delighted to introduce our speaker today, Dr. Ian Parney. Dr. Parney is a neurosurgeon and cancer researcher at the Mayo Clinic in Rochester, Minnesota. He received his MD, PhD, and neurosurgical residency training at the University of Alberta and subsequent training in neurosurgical oncology at the University of California, San Francisco. His clinical practice and research interests are focused on malignant brain tumors. Thank you so much for joining us, Dr. Parney. You may now begin your presentation.
Well, thank you very much for that introduction. It's an honor and a pleasure to be able to share this with the ABTA community today. So what I'm going to be talking about today is immunotherapy, harnessing the immune system to fight brain tumors. As you heard, I am a neurosurgeon here at the Mayo Clinic in Rochester, Minnesota. And I do have a couple of disclosures just to get out front at the beginning here. I have some grant support from the NIH, from the Ben and Catherine Ivey Foundation, from the Brains Together for a Cure Foundation. I'm also a medical advisory board member for a company called Agenus Incorporated, which is relevant to some of the information I'll be sharing with you about heat shock protein vaccines today. As I said, I'm a neurosurgeon, and we're, fairly good at neurosurgery these days. We can take a situation like this. This is a young man, 23 years old, who presented with seizures, and he had this very large, irregular enhancing mass in his posterior right temporal lobe, temporal parietal area. You can see this big, horrible-looking thing, and at surgery here, you can see the brain swelling out. We can use all of the tools that we normally have in surgery. We can use image guidance, an intraoperative MRI, the operating microscope, intraoperative electrophysiological mapping. This is an old Far Side cartoon where they say, you can't read it, I'm sure, but it says, press his brain here and see what happens, so just to map out the motor areas and things. So we can use all of these kind of adjuncts in surgery to convert this situation that's not with a big tumor to a situation like we've got at the bottom, the same patient, where we're able to get a gross total resection of this tumor. You can see that the brain is much less swollen now. He did extremely well and went home on the second day after his surgery. So if you'd say, well, if we can do that, why do we need to think about anything else for brain tumors, for malignant gliomas in particular? And of course, the answer is that these tumors, although we can get them out, they tend to have microscopic cells beyond what we can see that will come back at some point down the road, even with an aggressive operation. So there are other treatment options that, or a number of treatment options that are standard in neuro-oncology, as I'm sure most of you know. We can think about surgery, chopping a tumor out. We can think about radiation, burning a tumor. We can think about chemotherapy, poisoning a tumor, essentially. And these treatments work. There's no question that, particularly for glioblastomas, if you're able to get, the maximal safe resection followed by radiation and chemotherapy, you're going to be doing much better on average than if you didn't have these treatments. And by and large, these treatments are very well tolerated. But still, these tumors tend to come back afterwards. So we need to have something better. And there's a lot of people looking at a lot of different things. I've had an interest for many years in brain tumor immunotherapy, in trying to stimulate the immune system to attack a tumor. So what might this look like? Well, at a very simple level, if we're talking about a tumor vaccine, we want to maybe have something that we can inject just maybe underneath the skin that would stimulate an immune response against the tumor systemically that would go back and eradicate whatever tumor cells are left over in the brain after our surgery and radiation and chemotherapy. And the immune system is designed to be very specific, so that we hope that this would just attack tumor cells and leave normal cells unharmed, kind of like a silver bullet or magic bullet to eradicate tumors. So that sounds great. So why don't we just do all of that? Well, that's the question. How do we do that? And that's what I'm going to talk about a little bit today. Before we get into that, I think we need to talk a little bit about immunology in general. And I've titled this slide Immunology 101, everything you wanted to know about the immune system but were afraid to ask. And I think it's worth asking just a very simple question first. What exactly is the immune system? We all have a pretty good idea. I think I asked most folks, can you tell me, what makes up the nervous system? I'd say, well, the brain, the spinal cord, the peripheral nerves. If I said, what makes up the cardiovascular system, you might say, well, the heart and arteries, capillaries, veins. Sure, those, that sort of makes sense. But if I asked you what exactly makes up the immune system, well, it'd be maybe a little bit harder to answer. What part of your body is the immune system? Well, there are some specific tissues and organs that are primarily responsible for things in the immune system. And we're talking about things like lymph nodes, lymphatics, which are the channels that drain lymph nodes. The spleen in your abdomen has a major immunological function. But there are also a lot of other tissues and organs that you wouldn't necessarily think of off the top of your head as being important in the immune system, but have critical roles. The skin, the lungs, the liver, the gastrointestinal tract, the brain. All of these tissues have cells within them that their primary role is as part of the immune system. So when these are the tissues and organs that are involved, but really when we're talking about the immune system, we tend to be talking about white blood cells, and I'm going to be talking about a bunch of different types of white blood cells as we go on here. We think red blood cells are the ones that in your blood that carry oxygen. White blood cells are the ones that fight infection. They're the ones responsible for the immune system. So there's a lot of different types of white blood cells. There's cells called monocytes in the blood that when they get out of the blood and into the tissues, they become converted into something called macrophages. These are really important cells. They're kind of like the scavengers of the immune system. So if you have an area where there's been tissue damage, you might get macrophages that will go into that area and chew up all that debris and get rid of it. In the process of doing that, they also will sometimes present aspects of that debris to the immune system to stimulate the immune system against things that they find there. There's other cells, white blood cells called neutrophils and eosinophils and others besides that, but really the most important white blood cell that we talk about in the immune system is a lymphocyte. Now there's lots of different types of lymphocytes. There's T cells and B cells and natural killer cells and a number of different types of lymphocytes. But these are the ones that are really the workhorses of the immune system. And in particular, for some of the things that we'll be talking about today, we're interested in stimulating killer T cells that will go back and be activated against something in the tumor and then kill tumor cells, because that's their job. So just kind of in cartoon format what this might look like in a cellular level, and how you would get a T cell stimulated to attack, say, a tumor cell or something along those lines. One of the things that you have to have is something called an antigen-presenting cell, and I'm going to come back a little bit and talk about what an antigen is in just a minute. These are cells typically that are either macrophages or cells similar to macrophages, and in particular there's a type of cell called a dendritic cell, which is often thought of in the same family of cells as macrophages, that's really good at stimulating T cells. And so the antigen presenting cell will have a bunch of the machinery and things that it needs to get a T cell activated. The T cells are very specific for these things, antigens. So every T cell will only react against a certain antigen. So what's an antigen? An antigen is usually a protein or a short piece of a protein that the body recognizes, and specifically the immune system recognizes, as either foreign or dangerous. So for example, if you have a bacterial infection somewhere in the body, the bacteria produce proteins which aren't normal in the body, and the immune system will recognize those proteins and react against them. Similarly, if you have a tumor, the tumor will have proteins within it that are not normal or are dangerous, that the body and the immune system will recognize as being not normal or dangerous and will react against them. So the idea is that you would have these antigen-presenting cells present this antigen to a T cell that's specific for that antigen, along with all of the other things they need to get that T cell activated. And then this would sort of look something like this. Again, you've got your antigen-presenting cell, and maybe it's gone to an area where there was an infection or a tumor or something like that, and it's picked up some of these antigens. It presents those antigens to, in this case, a killer T cell, a TK cell. Gets a signal to stimulate and divide from that. There's also other types of T cells, a helper T cell that provides some other signals here. Then this killer T cell that's specific for this antigen is going to proliferate and divide. So you started with one, now you have many of these cells, and then they'll hone back through the body to the area where this infection is or where the tumor is, and maybe there's some other cells here that are either infected or maybe they're tumor cells, so they have all of these same antigens within the tumor. And these killer T cells, or now effector cells, are activated, will go back and kill the cells that have these antigens in there. That's what these little lightning strikes are supposed to represent, that the cell that has these antigens due to infection or because maybe it's a tumor cell is going to get killed by this T cell that's been activated against that specific antigen. So, okay, great. But if the immune system is so good, as you say it is, and we all have immune systems, why does anybody get a tumor? Because, you know, really, the immune system should recognize that the tumor is abnormal and eradicate it. So if the immune system's so good, how can tumors grow? Well, it's possible that, in fact, our immune system does get rid of a lot of tumors, that there may be sort of microscopic cells all the time arising that have the potential to form tumors down the road, but maybe our immune system just recognizes them and gets rid of them before they ever come to anybody's attention. But of course, we can get tumors. And so how does that happen if the immune system is so good? Well, it really comes down to this. Tumors are really, really good at turning the immune system off. And they can do this in a couple of different ways. One, they can directly kill white blood cells that have been activated against tumor cells. So if you get a good stimulus here and the tumor cell or the T cells are activated to kill tumor cells, the tumor cells are still pretty good at killing those T cells before they can have the effect that you want. They also can work indirectly, because what the tumor can do is convert normal white blood cells to a number of regulatory immune cells that sort of turn the volume down on the immune system. They make it hard to get immune responses activated. So the tumors have both direct ways to inhibit the immune system and indirect ways to inhibit the immune system. And you end up with a situation like this in brain tumor patients, what I call an immunosuppressive cell network. And what we want to see here is that you might have naive T cells that get activated after coming into contact with dendritic cells with the appropriate antigens. And then these activated T cells would go back and kill tumor cells. But the problem is that we have a series of other cells, the tumor cells themselves, white blood cells, monocytes that infiltrate the tumor and become immunosuppressive, and then some of these other regulatory cells, myeloid-derived suppressor cells, and regulatory T cells, that all of these sort of immunosuppressive cell populations will either inhibit the activation of these T lymphocytes or just kill activated T cells when they come into contact with them. So far, this is what I would describe as a gosh, cancer's bad talk. You know, gosh, cancer's bad, here's another way that it's bad. It's really good at suppressing the immune system. Well, I don't really like gosh, cancer's bad talks. I go to a lot of those at meetings. What I want to hear about is how we can do something better, that we can stimulate the immune system to do something. So how can we do that? How can we stimulate the immune system to do its job? Well, one way is that we can give a strong stimulus to get it going. And one example of that I'm going to talk about in detail here is tumor vaccines. And the idea here is that if it really does appear that if we can generate a strong enough immune response, we can activate enough of those T cells to go back against the tumor, it can kind of overwhelm a lot of the immunosuppression that is present in tumors. The other thing we can work at is to interrupt the tumor's ability to turn off the immune system. So give medications or other agents that will sort of modulate the immune system, immunomodulation. And I'm not going to talk about this as much. I'll come back and touch on it right at the end. But this is actually a really expanding area of research right now as well. So I thought I wanted to talk about vaccines for tumors. And you might be sitting thinking, well, that's crazy talk. I know what vaccines are. They're those things that you get as a kid to prevent, measles, mumps, and rubella and that kind of thing. But who ever heard of a vaccine for a tumor? Can you even do that? Well, yes, absolutely, you can do that. And I want to kind of go through a few ways that we can do this. What we're talking about here are therapeutic vaccines, not preventative vaccines. We're not trying to say that we would give every child when they start school a vaccine that would prevent them from developing a brain tumor later in life. Although I suppose if we get to that point, that might be something that we could look at down the road. But right now, what we're talking about is people who have a brain tumor. We want to give them a vaccine that's going to stimulate their immune system to go back and attack whatever tumor cells they have left over after their standard treatments. So how do you do that? Well, you need a few things. You need a source of tumor antigens, these little proteins or parts of proteins that are abnormal or dangerous and specific for the tumors. And tumors are chock full of tumor antigens, but you need a source of these tumor antigens. You also need an effective way to get the immune system to respond to those antigens. In other words, you need a mechanism to make a vaccine. And there's a lot of different ways to do that. I'll go through a few different approaches here right now. Probably the most widely tested type of tumor vaccine in general, and for brain tumors in particular, is something called a dendritic cell vaccine. You remember that dendritic cells, I said, were those monocyte or macrophage-like cells that are really good antigen-presenting cells and really good at stimulating the immune system. So what would a dendritic cell vaccine look like? So if this is a pretty good example, or I'll try and run through this in cartoon format. If you have somebody with a brain tumor, that's what this is meant to represent, you can take a sample of blood from that individual, and from their blood you can purify a type of white blood cell called a monocyte. These are those monocyte macrophage-like cells. And then take those monocytes into the lab in a culture dish, and under the appropriate conditions in the lab, you can convert those monocytes into dendritic cells, these very potent and powerful antigen-presenting cells. So this can be then the basis of your vaccine. You, of course, also need, as I said, tumor antigens. So how are you going to get that? Well, the most common way that people have done that is this, to actually just take the tumor itself at surgery and in various ways basically chop it up and get tumor proteins and antigens out from that. There's a lot of different ways that you can do that, but basically take it straight from a tumor when it's resected at surgery. The idea then is that you combine these two things, the tumor antigens and the dendritic cells, and you give them back, usually just as an injection underneath the skin, to the patient who was the source of the monocytes and the tumor proteins. And what we hope with this is that's going to take, this is meant to represent naive T cells that haven't been activated, that they're going to come into contact with these dendritic cells that have been primed with all the tumor antigens that we got from that patient, and that's going to generate activated T cells. They're going to go back and home to the tumor and eradicate tumor cells there. So dendritic cell vaccines have actually been around for quite a while, more than 10 years. And in terms of brain tumors, gliomas, there's been, I've got more than for a lot of things here because it's hard to keep up with all this, but there's been more than 16 clinical trials published for dendritic cell vaccines for glioblastomas or other gliomas. These have involved more than 10 different research groups across multiple countries and continents. And more than 350 patients have been reported their results from this. So it's been around a little while. We have a little bit of a track record in doing this kind of thing. But it's a little bit difficult to compare a lot of these studies because they're very different from study to study. There's large variations in the types of patients. So for example, some studies only included grade 4 tumors. Other studies included grades 2, 3, and 4 tumors. Some studies only included recurrent tumor patients. Others were at new diagnosis. So a lot of variation in the type of patients. A lot of variation in the methods that are used to grow these dendritic cells in the lab, which it turns out is actually really important, how you grow these dendritic cells, and I'll come back to that a little bit later on in the talk here. and lots of different measurements of immune responses. So almost every different study that you look at used a different way to measure an immune response. So it's very difficult to compare from study to tell which one is better. Nevertheless, there is some indication that something useful is going on here. If you look at least the glioblastoma patients, the grade 4 patients that were included in these studies, the average survival was about 21 months. Which, if you think about what we would have expected for average survival over that time period, 10 to 15 years, because these studies were published going back 10 years, probably the patients were beginning to be treated, a little bit before that. So over the last 10 to 15 years, this is a higher survival than you would have, or a longer survival average than you would have expected for most patients with glioblastomas in that time frame. So you get the sense that maybe something is useful is going on here. And there is at least one large multi-center phase 3 clinical trial underway for a dendritic cell vaccine right now. There may be more, but I know of at least one with Northwest Biotherapeutics, which is being headed up, the study by Dr. Linda Liao at UCLA. So dendritic cell vaccines have been around for a while, and there's certainly some promise. I'll come back to that a little bit later. It's not the only type of vaccine, though. Another vaccine that you may hear about right now, because it's there's a large study going on, is a heat shock protein-based vaccine. So what are heat shock proteins? Heat shock proteins are a category of proteins that are present in every cell in the body. And they normally act as what's called a molecular chaperone. They take other proteins or bits of proteins and they move them around the cell so that the cell can use them in the appropriate manner. And there's a particular type of a heat shock protein that is critical for moving antigens, in this case tumor antigens, around. So you might have one heat shock protein, but it will be associated with a bunch of different tumor antigens there. And so the idea here is that you might take a chunk of tumor taken out at surgery and isolate from that fresh tumor specimen heat shock proteins with their peptides that are bound to them, and use that to make a vaccine that you can just inject underneath the skin, again, to stimulate an immune response. This works by using dendritic cells not that have been cultured in the lab, so you don't have to do that dendritic cell culture, so it's one less thing that you have to do in the lab before doing this, but dendritic cells that are normally present in the skin. It turns out that these heat shock proteins are really good at homing to dendritic cells. They bind to a particular receptor on the surface of the cell, they get internalized, and then these dendritic cells will present those peptides or those antigens from the heat shock proteins to T cells to stimulate an immune response. There is right now, and really the bulk of the work that has been done on heat shock protein peptide complex vaccines in glioblastomas is the work of Dr. Andrew Parsa at Northwestern University, formerly at UCSF. And so through one of the big cooperative groups, the Alliance for Clinical Trials in Oncology, there is now open a protocol A071101, headed up by Dr. Parsa, for patients with recurrent glioblastomas. Have to undergo resection of at least 90% of the enhancing tumor and have a good functional status, and make a vaccine, and then patients would get either HSPPC 96, that's the vaccine, or bevacizumab. You may know that better by the name Avastin. So the patients will get randomized to one of 3 arms in the study. They either get Avastin alone, they get vaccine plus Avastin, or vaccine alone, and then get Avastin if when a tumor progresses, and then are followed up afterwards. And this is going to be for or planned for over 200 patients, and is now open at multiple centers across the United States. Open here at Mayo Clinic, but open at a number of other centers as well. So this does set some milestones for the National Cancer Institute. This is actually the largest cancer vaccine study ever in brain tumors. It's the largest solid tumor vaccine trial of any type of solid tumor in the last decade. It's a cancer vaccine study conducted in combination with Avastin, which is quite novel. It's a big, what we call autologous. That just means from the patient. Every individual patient's tumor is used to make their tumor vaccine. So it's an autologous cancer vaccine trial. So those dendritic cell studies that I talked about and the heat shock protein vaccines that I've just been talking about are what I would refer to as bulk antigen vaccine trials. So what do I mean by that? These are trials where the tumor antigens are obtained from the individual patient's tumor. And in a lot of ways, this is great. This is the ultimate in personalized medicine, because if you have a tumor, well, we've made a vaccine from your tumor. So, I mean, it's very personalized. You know that it's going to be relevant, and that's great. So, gosh, certainly we'd want to do this, right, of course? Well, there are some problems with bulk antigen approaches like this. Bulk antigens are a limited resource. In other words, you can only make as much vaccine as tumor tissue you have. Now, I'm a neurosurgeon who I make my living largely taking out brain tumors. It's one of my favorite things in the whole world to do, is to operate and take out brain tumors. Some of my patients, though, are not always as keen on having yet another operation, and I can respect that. You know, even if you do an operation and get the tumor tissue, it's still ultimately a limiting resource. You're only going to be able to give as much vaccine or make as much vaccine as you can get tumor tissue out, and eventually you're going to have to stop because you run out of vaccine. And that actually turns out to really matter. You tend to get a better response to any of these vaccines the more of the vaccine that you can give. The other thing that's really kind of a problem with these bulk antigen approaches is that it's hard to test for specific antigen-specific responses to particular tumor antigens. And well, why is that the case? Well, first of all, everybody's tumor is a little bit different. And so if I'm trying to design a clinical trial where I'm going to test for tumor antigen responses, but patient A's tumor antigens are different from patient B's tumor antigens or different from patient C's tumor antigens, it becomes really problematic to do that. I can't really design anything that's going to accommodate that. So why does that matter? Well, it does because of this. We all want to see this. Here's a guy taking the pitch, and he hits it out of the park. He's got a home run. And what I mean by that is we all want to see with our vaccine clinical trials that we've had a home run, that we've had a clear, unequivocal benefit to patients in terms of stimulating an immune response and survival afterwards. And the problem is with all of these studies is that really hasn't happened yet. We see things that make us think that, yeah, there's probably some benefit here, but it hasn't been a home run like this where we can sort of unequivocally say we got it. And with that in mind, the National Cancer Institute has actually turned around and said, we understand why you want to use bulk antigens and it's personalized medicine, and that's great, but until you start showing us that you're getting some home runs like this, we really want you to test specific antigen responses, because at least that way we can decide have you actually stimulated an immune response that is relevant, that you said that you were going to stimulate in doing this, and you can compare much better from study to study and looking at different approaches to vaccines if you're testing for specific tumor antigens. So, so people have done that and looked at that and said, well, we're not going to do these kind of bulk antigen approaches. We're going to do other vaccines that are directed at particular tumor antigens. And probably one of the most developed of these approaches is this Celldex product, CDX110. So this is a vaccine that's just a molecule. There's no cells involved, not really any proteins or anything like that, just a little bit of a portion of a protein from a particular tumor antigen, EGFR V3. EGFR is a normal protein that's present in many cells. EGFR V3 is a mutant protein that is only present in tumor cells, and it's present in a number of brain tumor patients where this particular receptor is activated all the time, and it drives the growth of these cells. course, one of the things that drives the growth of these cells. So you can make a vaccine that is just purely directed against this one antigen. It doesn't involve any cells. It just involves the molecules and a portion of that antigen to test the response. And John Sampson at Duke University and Amy Heimberger at MD Anderson have really done a fantastic job with this. And this is some of their data from a clinical trial looking at outcomes for patients with glioblastomas that were treated with the vaccine, the EGFRV3 vaccine, looking at their survival over time compared to patients that didn't get the vaccine. Now, this was not a randomized study. It's not like these patients were randomly chosen to get this or that. These are the patients that went on to the clinical trial. These are historic control patients. Now, they did a pretty good job, actually they did really a very good job in this study of matching the control patients to the patients in the clinical trial. So it's a reasonable comparison, but it's not like it's a randomized study, and so you have to take it with a little bit of a grain of salt. But it does look like there was a clinical benefit to this vaccine in terms of increasing survival. But there's some problems with this kind of approach, whether it's EGFRV3 vaccines or other vaccines directed against sort of a single antigen or even a couple of antigens like this. First of all, they tend to be for highly selected patients, and specifically in that study, it was only for patients who had a GTR, a gross total resection, so more than 95% of the enhancing tumor. That's not always possible in every case, depending on where the tumor is. Obviously, it's only going to be an option for patients whose tumor expresses the EGFRV3, and not every patient with a glioblastoma does express this. If you are conservative, probably only about 20% of patients with glioblastomas have tumors that express this protein. So it's not going to be for everybody. The other kind of problem or sort of conceptual problem with a vaccine that targets a single antigen like this is the problem of immunoediting. So what do I mean by that? Well, if you're a tumor and your cells are expressing a lot of protein like EGFRV3, which is abnormal, and then somebody stimulates an immune response that's going to eradicate any cells that express the EGFRV3, well, the first thing that the tumor is going to do is just stop expressing EGFRV3 and use other mechanisms to continue to grow in its absence. And that's really exactly what happens in this study. So all of the patients enrolled in that study had tumors that were positive for EGFRV3. That was a requirement to get into the study before they got the vaccination. Although there clearly seemed to be some prolonged survival in the patients that got this vaccine, most patients eventually had their tumor recur, and a subset of those patients went on to have another surgery when their tumor recurred. And when they looked at the EGFRV3 antigen in the tumors that recurred after vaccination, most of them, more than 80% of them, had actually lost the expression of this protein when they recurred after vaccination. So on the one hand, as an immunologist, this is really exciting because you say, wow, we really generated an immune response against an antigen. Isn't that great? But for patients, this isn't so great because it just says, well, the tumor's escaped by doing immunoediting, and we want to do something that's going to avoid that. So what would maybe be an ideal antigen source for tumor vaccines? You'd want something that maybe combined the best features of both a bulk antigen and specific antigen approaches. So I'd like to have something that contained many tumor antigens, much more than just sort of one or two or things like that, because then it's going to be much harder for the tumor to just stop expressing all of those antigens than if they just have one. I'd like something that would allow antigen-specific immune response testing so that I can really say, did we generate with our vaccine the immune response that we said we wanted to generate with this vaccine? I want something that's widely available, that does not require fresh tissue, because that tissue just often is not available or is limited when it is. So to that end, we have opened up at Mayo Clinic this trial, MC1272. It's a novel dendritic cell vaccine in newly diagnosed glioblastoma patients. We think that this has a better source for tumor antigens. We think that we actually have better dendritic cells than people have had in the past, and I'll talk about that here a little bit. And I think we have better immunological monitoring than we've had in the past with a lot of vaccines. So better source for tumor antigens. What do I mean by that? Well, what we've done in this case is rather than using patients' individual tumors as the source of their tumor antigens, we have grown under good manufacturing practices conditions. That's the sort of clinical grade lab. So this is a lab where people wear spacesuits and you know, it's very highly regulated. So in that scenario, we've created a library of cell cultures from other patients with glioblastomas that we resected. And we have these cultures growing sort of essentially indefinitely in culture that we can use as a renewable source of antigens. Now, we have looked at, this is just from 7 of those lines, expression of a number of common tumor antigens. That's what all of these various things are. This is something called the Western blot. You can see that, you know, some of these cells express some of the antigens, some of them express all of the antigens. There's quite a bit of variation from time to time, or from line to line. But the point is, we have a defined antigen source that's renewable that we can use to make a vaccine for anybody. But it's not like this vaccine only includes these antigens. We assume that these cell cultures that we've generated have many, many, many abnormal proteins that are potentially available to the immune system to respond against. So it's going to reduce the chance of there being significant immunoediting when we use this source of antigens with a lot of tumor antigens. But yet at the same time, it's going to be renewable so that we can keep giving vaccines for a longer period of time. And we know at least some of the antigens that are present so that we can test for specific antigen responses after giving the vaccine. So I think we have a better way of making dendritic cells. Well, what do I mean by that? So it turns out how you make dendritic cells, how you culture them in the lab from those white blood cells called monocytes really matters. What you want to get at the end of your process of making these dendritic cells are mature dendritic cells. Because if you don't do this right, you can end up with immature dendritic cells. And while mature dendritic cells stimulate the immune system, immature dendritic cells inhibit the immune system. One marker for mature dendritic cells is a protein called CD83 that's present on the surface of those dendritic cells. If you look at, in the black circles here, this is healthy donor samples. The red triangles are patients with glioblastomas. If you use a standard technique to make dendritic cells, this has been optimized with normal healthy donor blood samples. You can get a lot of mature dendritic cells. This is what you really want. The problem is that glioblastoma patients, their blood is not normal. Their monocytes are not normal, and they include a number of these regulatory cells that suppress immune responses and turn things down. And if you use the same technique that works really well with healthy normal donors in glioblastoma patients, you get a whole lot of immature dendritic cells, which are probably actually counterproductive. This work represents work from one of my colleagues here at Mayo Clinic, Dr. Alan Dietz in our human cellular therapy lab. And what Al did, which was really smart, is that he went through a whole series of different techniques to culture dendritic cells with glioblastoma patients until he came up with this technique here. We call it the DC-opt4 technique, where we are finally getting numbers of mature dendritic cells that are comparable to what we would get with this technique that was optimized in normal donors. So it's this DC-opt4 technique that we use now to make our dendritic cells. We think that that's a better way to make them. And I also think we have better immunological monitoring, and this gets back to being able to test those antigen-specific responses. But not only that, we have developed a simple method to independently determine expression of over 120 immune molecules on white blood cells using very small blood samples, just 5 milliliters, and we get a very detailed characterization of the immune response with this. This has actually been really powerful. This is, again, Alan Dietz, one of my collaborators here, along with John Wolfest, the late John Wolfest at the University of Minnesota, in an earlier vaccine study they used this profile. In this case, it was only looking at 50 markers. We now have 120 markers, and this is a complex picture, I know, but I'll try and walk you through this. Essentially, what you're seeing on this axis here, these are different immune cells or white blood cell subsets. And if you've got a blue bar on one of these subsets, it means that you have fewer of them. If you have a gray bar, it sort of has an average number of them. If you have a red bar, it means you have more of them. There's actually kind of three populations of people represented here. These ones in the center that look green here, so all the way along here, these are normal, healthy volunteers. This is what normal patients, normal people, what their peripheral blood looks like when we look at the immune system. This population up here, from there to there, so everything on this side, and this population down here, from here to here, these are both patients with glioblastomas, with brain tumors. But what's very interesting here is you can see that these are actually different populations. The three distinct populations. There's the normal donors, and there's glioblastoma patients here, glioblastoma patients here. These glioblastoma patients tend to have more of these cells here. These are red, means that there's more of them, and these are the regulatory myeloid-derived suppressor cells, so cells that inhibit the immune system, whereas these glioblastoma patients had fewer of those cells. The other thing that's really been very exciting with this result is that these patients were ones that had some evidence that they responded to the vaccine, whereas these patients generally didn't respond to the vaccine. And this blood test was done based on a blood sample that was taken before they got vaccinated. And so this is very exciting. We're trying to reproduce this now with a second study in our ongoing clinical trial. But the idea is that we might be able to identify what patients are going to respond to the vaccine before we give it, and then we don't. These patients are going to have maybe some benefit. It may not be as beneficial for this group of patients up here, and so we can move on to other studies or other options for these patients. So we think that's a very potent way to look at the immune system. The other thing, of course, I'm just going to skip over this for time, this slide, but the other thing with this is now we can sort of look at this in different ways. This is a healthy volunteer, a bunch of these different immune cell populations. This is a glioblastoma patient who had a lot of these called lineage negative cells. Again, those are those immunosuppressive monocyte or myeloid-derived suppressor cells, kind of orange there, like this. This is the first patient in our vaccine study here, the MC1272 that I've been talking about. And thankfully, he looks more like the healthy volunteer than this other glioblastoma patient. So we're hoping that he's somebody who's going to be responding well to our vaccine. In the same patient, we're able to test for specific antigen responses. And again, very exciting here because we know what we're vaccinating with. We're able to detect that. So this population of cells here is the number of CD8, or in this case, killer T cells that are specific for this tumor antigen, something called GP100. And this is just a negative control where you don't see any of those cells. But you can see that in this patient, almost 1% of his killer T cells have been activated against this tumor antigen. And that's really exciting. I mean, 1% may not sound like a lot to you, but if you think of all the T cells that you have in your body, if we've activated at least 1% of them against this one antigen, and we have all these other antigens that may be getting activated as well, that's pretty hopeful and promising that we're going to be generating an immune response that could be helpful for people. So this study is ongoing. Our recruitment is a little bit slow just because the FDA has required us to go slow for the first 3 patients to make sure that there aren't any significant complications, and there haven't been so far, which is good. It's in combination with surgery, radiation, and temozolomide chemotherapy. And then after the radiation temozolomide, patients get temozolomide and vaccine together up until the 6th cycle, and then they get the vaccine alone for 7 to 12 cycles after that. Well, what about those patients with an unfavorable immune status? I said our preliminary data suggested that maybe there are some patients that just don't respond to the vaccine, and we might be able to identify those patients by our immunological screening. Well, we want to do something for patients in that category as well. So I think one of the key things as time goes on is that we'll be using a lot of these immune modulating therapies plus or minus a vaccine. So these are therapies that are designed to reduce the tumor's ability to inhibit the immune system. There's an old-fashioned type of doing this called surgery. You know, if we take out the bulk of the tumor, well, there's a whole lot less of it there to inhibit the immune system. So that's something I think that's important if we can do it. But there's a whole bunch of what I described as newfangled ones, which I'm not really going to talk about today, but are increasingly important. They're immune checkpoint blockade. So there's a medication called ipilimumab, which blocks a molecule called CTLA-4, which has been used to a great degree in patients with melanoma to help stimulate their immune responses, and people are beginning to look at that in glioblastomas as well. And there's another immune checkpoint called the PD-1, PD-L1 axis, where there's a number of antibodies that are directed at that are now coming into clinical trial as well, both here at Mayo Clinic and really all across the country for patients with malignant brain tumors. So we're hoping that this is something that we may be able to utilize to help patients with more unfavorable immune status become favorable so that they might respond to the vaccine. So just to conclude with that, I'd say immunotherapy is a promising experimental approach to brain tumor treatment. I think most commonly this involves therapeutic vaccines combined with standard treatments. In the near future, I think immune modulating agents will also be available in clinical trials. I just want to acknowledge a number of the people that I work with here and elsewhere who've contributed to this in my lab and Dr. Dietz's lab through our Mayo Clinic Brain Spore Group and at the University of Minnesota. And I'll stop there and would be happy to answer questions.
Thank you so much. That was an amazing presentation. I hope everyone learned as much as I did from that. It is such an exciting field that's coming up, and it's amazing what you can do with all this. So it would be exciting even to kind of come back together in a year even and see what has changed with immunotherapy. So it's exciting. So we do have some time for some questions. I'll just remind you that if you do have a question, you can type it and submit it using the question box in the webinar control panel on the right side of your screen. So we'll start and we'll see how many we can get to. Let's see. Someone is asking about how long does the anti-PD-1 MK3475 usually take to show results? And she's also wondering, are there trials planned in brain tumors combining vaccines, the anti-PD-1 or the PD-L1?
Right. So I think that's an excellent question. I'll just maybe repeat that so that everybody understands. The person is asking about a particular antibody, MK3475, I think it is, that is directed against one of these immune checkpoint blockade against PD-1 specifically. And I think there was two questions in there. How long does it take to have the effect? Will this be combined with vaccines in the future? So how long does it take to have an effect? So first of all, I would say the use of these immune checkpoint blockades in brain tumor patients is really in its infancy. I think there are a number of clinical trials that are just beginning to get going, and maybe this person is under treatment right now, which would be great. But I don't know that we have a really great answer to how long it takes to work. What I can say is that based on other tumor types where people have been treated with these PD-1 inhibitors, including that one specifically, what most commonly happens is if you just look at the imaging, the tumors actually look like they get a little bit bigger first for a few weeks or even a few months, and then they begin to shrink after that. And the thought is that getting bigger may not actually be the tumor growing. It may be kind of the inflammatory response against the tumor that just makes it look like it's getting bigger, and then it sort of shrinks down a little bit afterwards. But that time course for that, at least in other types of cancers, and particularly in melanomas, is measured over sort of weeks to a few months. And then the other question with that was, when will these, or will they be combined with vaccines? And I think absolutely these are going to be combined with vaccines, and that's something that we're very interested in doing here. And I know many other people around the country are interested in that as well. I think we probably need to get a little bit more data, a little bit more information about how brain tumor patients respond to treatment with these inhibitors by themselves first, so that we can sort of have our baseline, and then probably we'll be looking at combining these with vaccines down the road. I would imagine probably within a year or so.
That would be great. Someone is wondering about metastatic, which is something that, here we take questions and callers who have metastatic tumors as well as primary brain tumors. So if they have a metastatic cancer, can this type of immunotherapy work on metastatic cancer?
Yes, I think I would say that there's potential for that. It really, all of these immunotherapies are experimental right now, so that whether somebody with metastatic brain tumors is going to be eligible for clinical trial would really depend on the specific clinical trial. And I have to say, unfortunately, a lot of the clinical trials for vaccines or the immune checkpoint inhibitors in a lot of other systemic tumors, whether it's melanoma or renal cell carcinoma or lung cancer or breast cancer or so forth, they will often specifically exclude patients who have brain metastases unless those metastases have been kind of definitively dealt with by either surgery or radiosurgery or something along those lines. I'm not aware of anybody doing clinical trials making vaccines based on brain metastases themselves, but it's something that certainly could be done, and actually something that we have a little bit of interest in exploring here as well.
All right. I'm going to try to fit one or two more in here. Are there any immunotherapy dendritic cell vaccines in the United States that do not require inclusion of the brain tumor cells organized to be taken from surgery?
Yes, there's the study that we have open here at Mayo Clinic, MC1272, which we use as a tumor antigen source these established clinical grade human glioblastoma cell lines from other patients. So we don't need to get brain tumor tissue from each individual patient to make the vaccine. So yes, we have a study like that that's open. There may be others around the country as well that are open that I'm not aware of, but absolutely there are. Our own study, as I said, FDA has kind of limited us for our first 3 patients. We have to make sure that everybody does well in the first 3 patients before we can really open enrollment to more beyond that. But we're going to be getting there soon, probably in about 3 months.
Wonderful. And if anyone is interested in how to search for clinical trials, they're welcome to call us at the American Brain Tumor Association. Our number for our care line is 800-886-2282, and we've partnered with Emerging Meds and have Trial Connect, and we can connect you with that service to look for clinical trials in this category and other categories to see that you can find the best one that will work for you or your family members. So that's a lot of people were asking questions, doctor, about that, like how do I even start to find a physician? And as a social worker I always talk about contact your insurance company, but it's also a matter of what other treatments you've had, right?
Right. Every individual clinical trial has specific inclusion and exclusion criteria, and not everybody will be eligible for every study, but there are many studies out there, not just the immunotherapy studies, but of many different novel treatments, and yeah, I think the ABDA is a great resource. One of the other things that you can look at is clinicaltrials.gov online and look up brain tumors, and that can find a lot of different trials that are open at various places across the country.
That's correct. So yeah, definitely multiple sources to get your information, and we're always happy to help you, after this presentation if you have any questions. Just as a reminder too, the presentation does post to our Anytime Learning Anytime Learning section of our website, www.abta.org. So you can listen to this over and over if you have time to, and you want to listen to questions over because it is, a new subject, a confusing subject to some people. So it's always there. So we are at the top of the hour, so I want to respect everyone's time and, end on time. So we're going to say that that's all the questions that we have time for. Also let you know for more information on immunotherapy is available at our website, or we can also, again, if you call the care line, we can mail you information. Once again, Dr. Carney, thank you so much. You are a walking wealth of information. Just really appreciate that you took the time, not only today, but in the weeks and the months that we've been working with you to put this together for us. So thank you again.
It's an honor and a pleasure. Thanks very much for the opportunity.
I'm going to pause for just a second, and we are going to stop the webinar recording, and then I'm going to do a little bit more housekeeping.